So let me start this case. This is 84 years old female and stable angina, and patient had prior bypass, but unfortunately only right bypass is open, so we have to treat this 111 distal left main lesion. And based on the IBAS guidance and procedures, decided to do the keloid stenting, and this is a final angio, looks good. Unfortunately, patient coming back 2 months later, suffered by non-STEMI. And you can see, looks like the osteosarc, looks like some thrombus. I didn't show the index IBAS. This is how it looks like at the end of the procedure. So already MSA is 7.8, which is okay. And the left main MSA is 9.1, maybe okay. The osteosarc is only 5.2, which is not okay. And you see the carina site, there is no slat. On the other hand, 2 layers of the slat in non-carina site. And that's the issue. And this is IBAS probac at the index procedure at the end. This is LAD, and this is a left main. And it's super quick. I'm going to show one more time. This is circumflex. And here, that's a carina, no stent, and small dissection. And the point of this IBAS picture is, I don't think everybody can understand this IBAS. It's super quick, but importance is we should not look for everywhere. The most important point of the distal left main bifurcation by IBAS is really within 5 millimeter at the site of the carina. Those are the most issue occur, such this case. At the baseline, there is no stent in the carina site and double layer in the non-carina site. Because during the keloid stenting, the wire is too distal and then bringing the carina slat into the non-carina site and then leaving the small dissection. And 2 months later, you see the organized thrombus on top of the carina. This is how it is. But I do think most of the people, when we look into this picture, maybe okay, and I cannot put any more stent, even some non-covered segment, I'm going to leave it alone. That's, I think, the most people think based on this IBAS picture. I think this is actually too late if you find this type of issue. We have to prevent or we have to predict occur such issue. When we look into the Excel and having the patient two-stent technique, and we see multiple kind of mechanical issue. Number one, the clash is not very good enough. We see like the multiple layer of the slat at the carina and looks not enough clash. Number two is like the case I showed today. No matter how it looks like stent technique, we see gap at the site of the carina. And even we open up the cell, and still we see a lot of stent slat at the bifurcation. Those are the issue. We had 127 cases having the IBAS from both sides at the end of the procedure. And those type of the mechanical issues not infrequent. Incomplete clash, defined as more than 0.5 millimeter thickness of the stent slat, was found is 28%. And the gap, like I showed today, is 11%. No matter what kind of technique, we see this type of issue. If that is keloid, more likely carina site. If that is two-stent, more likely non-carina site. But this time, there is no decay clash. And if we do the decay clash, that could be slightly different. But I think the point was, the quality of the two-stent technique is the most important from the beginning. And think about the left main bifurcation, it's really diffuse disease. And if you look into the IBAS, we see this pattern. Including 140 cases, we look into the distal left main bifurcation. No matter how it looks like angiographic appearance, 90% of the time, we see the plaque from the LAD to the left main. But recently, I will explain slightly differently. LAD, no matter how it looks like angio, there is a plaque. Actually, the unique point is actually osteosarc. Sometimes the osteosarc plaque is from the sarc to the left main, but sometimes quite isolated, or sometimes nothing. So actually, the distal left-hand bifurcation, there is much more variation in the ostial circ, which actually more important to decide what is the best way to do the either provisional or two-stent technique. And this is the data in the Excel and definition registry. We ask the operator by looking at the IBUS for both sides, did you change your strategy? And answer is yes, is actually not infrequent. And interestingly, originally they decide, I go to the provisional, but they decided to stent or the other way around. So really, looking for the angio, you cannot understand what looks like the disease distribution. And key point is really looking for the circumflex. And we ask ourselves, including the Excel and the other study, when do we see the bailout stenting into the circumflex after the provisional stent? And then we ask, how looks like the original plaque morphology at the circumflex ostium? And pattern-wise, small lumen area at the ostial circ, or calcified nodule, or layered plaque which indicating the organized thrombus in the left main making the plaque shift. Those are the predictor to predict the bailout stenting if you decide the provisional. And if you look into the other data, how often we see this type of bailout is actually 1/4 of the cases. And then it's not infrequent, even though we decide provisional, 1/4 of the time they are going to the bailout. So really looking for the ostial circ and making the good plan is really making the good stenting. And how we can avoid this type of the mechanical issue is actually quite easy. When we do the DK clash, after the stenting the side branch and clash and rewiring, we can do the IBUS from the LAD to the left main. And then if you do this picture, look for the wire into the circ. And then bringing the IBUS plane into the circumflex wire, you can make the good longitudinal picture to showing the wire location. So this is the perfect location for the DK clash, and we can check again after the second DK clash as well, before second DK clash. And this is totally different aspect in terms of the deformation or mechanical issue in the left main. And this is actually very famous case in the Excel. It's very ugly left main lesion. And after the stenting from the LAD to the left main, the operator recognized there is under expansion in the distal left main. And then he dilate more. And after the dilatation, you see the distal left main looks very good. However, this is only one stent. However, I see the double layer of the stent in the proximal left main. This is so-called deformation because of the guide is pushing to the proximal stent and making such small area. And because of this, in the stent area actually decreased in the proximal left main, now is 6.4. And we ask, when we see this type of the issue is 6.5%, and then they are poor outcome. And then when we look into with without the deformation, look for the what is the patient characteristics, is very clear. Having the deformation, there are more disease, longer stent, longer procedure. It's actually very complex lesion compared to the other. And then, interestingly, if you look into the IBUS, actually, protruding stent into the aorta is almost same. So meaning, they are really complex patient. And actually, sometimes you try, but cannot avoid. And what is important is really the recognition. At the end of the very complex left main stenting, you really have to disengaging the guide and checking the IBUS up to the end of the stent, not having the deformation. And if so, we just have to open again to optimize. That procedure is quite necessary. So altogether, distal left main bifurcation lesion, I do think ostial circ evaluation is actually more important. And after two-stent technique and distal left main bifurcation, mechanical issue is not infrequent. So the two-stent is not a decision. Good quality of the two-stent is important. And after the left main PCI, we see 6.5% of the deformation. And you can try, but sometimes it's impossible. But recognition is important. Disengaging the guide, confirming what's happening at the end of procedure is the most important. Thank you.